Thank you very much for joining us today. Okay, our chapter director, who will be moderating this session. Behind the scenes, ensuring that everything runs smoothly is Mr. Pato. We extend a big thanks to. It's a pleasure to welcome you to our 30th bi-monthly webinar. Today's topic is integrated behavioral health approaches in substance use disorder, prevention, treatment, and recovery, bridging gaps in service delivery. This is an extremely important discussion, especially as we continue to strengthen efforts to improve outcomes for individuals and communities affected by substance use disorder. For those joining us for the first time, ISSUP, the International Society for Substance Use Professionals, the global network of professionals working across prevention, treatment, recovery support, and harm reduction. A few numbers to give context. ISSUP has over 47,000 members in more than 200 countries and territories, and 41 national chapters, including ours here in Nigeria. Membership in ISSUP provides access, training, technical credentials, and a platform to share knowledge and best practices with colleagues worldwide. It is free to join and take just a few minutes. If you are interested to become a member, you can visit www.issup.net. Before we get started, a few housekeeping notes. There will be a question and answer session at the end of the webinar. Please type your questions in the chat and we'll address as many as we can. A recording of this session will be made available so that you can revisit or share it. This webinar is for information and learning purposes only and does not constitute medical advice. I would like to note that today is a particularly special occasion for ISSUP Nigeria chapter. We are delighted to welcome our new president, Dr. Lajumoke Koyojo, who succeeds Dr. Martin Agodi, a remarkable leader who has supported this webinar series since its inception. Today marks a new chapter of leadership and growth for our webinar, and we are excited to continue advancing ISSUP mission under Dr. Koyojo's guidance. It is my pleasure now to introduce today's speaker. Why Dr. Mohammed Audu was originally scheduled to speak today. Due to unforeseen circumstances, he is unable to join us. We are therefore delighted to welcome Professor Ehigiato Okokwe Adoyonfo as our presenter for this session. Professor Adoyonfo holds a Bachelor of Medicine and Bachelor of Surgery from the University of Benin, as well as a postgraduate diploma in Community and Social Services. He is also a Fellow of the Medical College in Psychiatry and has completed certifications in Information and Communication Technology, Addiction Prevention in Prague, and Addiction Management in Bangalore, India. He is a professor and consultant in addiction psychiatry and currently serves as the head of the Department of Mental Health at both the University of Benin and the University of Benin Teaching Hospital in Benin City, Edo State, Nigeria. Please join me in warmly welcoming Professor Higiato Okokwe Adoyonfo. You are welcome, Prof. The floor is yours.
Yeah, thank you very much, everybody, and good afternoon from Nigeria. As has been stated, Dr. Mohammed Audu supposed to be the presenter. Indeed, these slides or PowerPoint was prepared by him. So I'm only going to be speaking to the slides. Thank you. And then the topic is integrated behavioral health approaches in substance use disorder, prevention, treatment, and recovery, bridging gaps in service delivery. By way of introduction, substance use disorder, aka SUD, continue to be a major problem all over the world, more so in our country, Nigeria. And the strategy of integrated behavioral health, abbreviated IBH, is a strategy effort that is geared towards mitigating the fragmented healthcare system for people that use substances. Because the fragmented system that we ordinarily have in our country fails to meet the holistic need of SUD patients. Therefore, this talk this afternoon, we'll be looking at the various ways, models, strategies, and innovations that we can employ to bridge the service delivery gaps as far as people who have SUD are concerned. Essentially, what is this talk about IBH? It is a system that tries to look at SUD patients in totality, a system that recognizes that people who use substances, like every other human being, have physical illnesses. They can also have mental health problems. And indeed, we have evidence to show that the people who use substances, people who have SUD, have a higher prevalence of mental health illnesses and indeed physical illnesses. And therefore, IBH try to coordinate health delivery to SUD patients in totality. So instead of the fragmented system of, oh, take treatment here for SUD, take treatment somewhere else for high blood pressure, take treatment somewhere else for example, depression, IBH try to link all these services together for the one person who has a substance use disorder. Therefore, what are the principles of IBH? Number one, it looks at the person in totality. That is, it looks at the psychological health, the physical health, and indeed the substance use problem of the person. It is also a person-centered care, which means the services are not imposed on the person who has SUD. The services recognizes, or IBH recognizes, that people who have SUD problem, they should be treated or seen as autonomous persons who should be able to contribute to decisions concerning their care. And so there is shared decision making. So, providers of these various healthcare services go into interaction with the patient, and then decisions are reached concerning how the patient or person should be looked after. And then it's a team approach, matter. So you have different experts coming to work together through this pipeline of IBH to render services to an SUD person or client. And so you can have the psychiatrist, you can have the primary care physician, you can have the case manager, social worker, and so on and so forth. Everybody working together under IBH to look at the totality of the person who uses a psychoactive substance. And of course, there is continuous quality improvement. IBH is a progressive exercise. As the services are being rendered, lapses are recognized, properly documented, analyzed, and therefore the process continuously improves without any limit. Then what are the framework levels for IBH? 3 are identified here: coordinated care, co-located care, and the fully integrated care. In the coordinated care, the physician or the healthcare professionals who attend to the physical health, those who attend to the mental health, and those attending to the SUD problem, like the counselors and psychologists, they are coordinated. They are not in the same place. They may be wide apart, but there is a linking. There's a coordination. Everybody is carried along. That is a coordinated care. In the co-located care, you have these various professionals in the same building, in the same location, like happens in most teaching hospitals. You have, the primary care physicians working in GPC or family medicine. You have those who treat the cardiologists in the same hospital. You have the counselors, the psychologists, dealing with the primary problem, SUD. And then you have the psychiatrists and others who may be looking at depression. They are in the same location. And then you have the other one, the fully integrated care, which describes the clinical circumstance, where all these experts are mentioned. They form a team. They are in a team. They are in they are in a team. So you have a team of people or professionals treating people with SUD, and then when they carry out ward rounds, even when they are in clinic, all of them, all the team members are there together. So you have the psychiatrist, you have the medical officer providing primary care services, you have the counselors there, you have the psychologists there. So that is the fully integrated care, which indeed is the ideal. What are the statistics? What is the situation? 1 in 8 people worldwide has got a mental disorder. Indeed, for most countries, it's between 1 in 4 to 1 to 8 persons having a mental disorder. And then 35 million persons live with drug use disorders. This is as reported in 2023 by the WHO. With regards to Nigeria, the NDLEA, National Drug Law Enforcement Agency, reported in 2022 that 14.3 million people in Nigeria use the psychoactive substances. Indeed, this just apply, to some, demographics in Nigeria. People 15 to about 65 years old. As I tried to allude to earlier, there's a high comorbidity of mental illnesses, depression, anxiety, and indeed traumatic conditions among SUD patients. And it is sad to note that less than 1/3 of people that have SUD, get a treatment. No thanks to severe shortages of manpower. So why do we need to have integration? Why do we need to have integration, therefore? Why are we talking about IBH? Why are we discussing it? As stated, many SUD patients experience mental health problems which are untreated. The system we have is, largely fragmented, and then this impairs recovery. When you integrate, there are many gains. Some of the gains are reduction in stigma, improve access to treatment, and indeed, it becomes cheaper. So you imagine that you have a team of professionals looking after persons with SUD. And in that team, you have those who can attend to primary healthcare issues. You have those who can attend to mental illnesses. And then you have drug counselors and what have you. So instead of going to meet these professionals separately, they are met together. And so that improves access and, of course, reduces the cost for the patient. And when there is integration, recovery is sustained because biopsychosocial approaches are employed. Yes, social workers are there, psychologists are there, psychiatrists are there, and so all the aspects of the patient are looked at. And so when all these are considered, and knowing the implication of biopsychosocial issues in SUD, you can then readily appreciate how a patient who enjoys this integration is likely to, maintain recovery over time. What are the practical IBH models for low resource setting? One is collaborative care model, which is essentially what we have been talking about. And then you have the screening, brief intervention, and referral to treatment. Here, what you can do is to empower professionals who work at primary health care centers so that we build their capacity. They are therefore able to screen for mental health problems, able to screen for drug use problems, and then they are also then able to carry out, brief intervention. And of course, they are linked to a center that they can refer to. And then we have the stepped care model, which describes a situation where you say, okay, because of paucity of manpower, as we have in our setting, let us, graduate care into various levels, so that at the lowest level, what we do is to give a patient education, provide printed material for them, see them, help them to adopt, lifestyle modification that will help them to stay off the use of psychoactive substances. And so when this, when they are not able to succeed, at this, personal level of empowering them to look after themselves, to provide care for themselves, they can be taken to the next level, which is psychologists and counselors can come in to render psychosocial support. Again, when this is done and we do not get satisfactory results, they can be taken to the highest level where they are saying the top-notch experts, addiction psychiatrists, addiction psychologists, and counselors, usually in an hospital setting, and this usually will include inpatient care. And then we also have the practice of task shifting and task sharing. Again, task shifting is not too different from SBROT, because what happens here is that you empower, professionals with capacity that are ordinarily, accrued to people who are highly specialized. So to break this down, what this means is that a psychiatrist, a consultant psychiatrist, can train community health extension workers in a primary care to be able to screen for depression and provide some treatment. So what you have done is to shift responsibility meant for a higher officer to somebody ordinarily does not perform such task. But again, task sharing is preferred, which simply means that you have people in a team, each team member doing his or her own work. For example, you can have the drug counselor doing counseling, the psychiatrist prescribing for depression, and then the social worker coordinating or performing the role of a case manager. So that is task sharing. Again, this model are there to enhance early intervention and optimize limited resources. You begin to appreciate, as stated, from the very outset, that IBH is multidisciplinary. And this slide is showing you the various experts that are involved. Psychiatrists, psychologists, even peer providers. Peer providers, these are people who were SUD patients. They have been treated, they have sustained recovery, and they are now even helping, they have joined the treatment team, helping people who currently use their substances to deal with SUD problem. And what do they do? The team members shared assessments, and regular reviews. IBH is, like we said, is a strategy that continues to undergo, improvement. And as such, in this time and age, where everything is going digital, IBH is also leveraging and must indeed leverage on the digital healthcare innovations. And so can be tele-counseling and tele-psychiatry, especially for remote areas. Therefore, counseling, medication review, screening, and what have you, they can be done through something as basic as, SMS, WhatsApp messages, telephone calls, audio and video calls, and so on and so forth. And so there can be apps that can even remotely screen for substance use disorder, screen for mental health problems, and such patients can be so followed up. IBH is data-driven. Otherwise, there cannot be a place for improvement. So it is the analysis of data over time using digital system that tells you, whether what you are doing is right, whether you are getting results, and what improvement you may need to bring to bear so that you can optimize the services we are rendering. And of course, artificial intelligence is also taken advantage of by IBH. For example, there are wearables like wristwatches, they call them smart wristwatches, that clients can wear, that can help to predict relapse. There are wearables that can alert a patient oh, you are about to relapse. Such wearables or AI system can also be linked to even service providers, so that when our patient is at risk of relapse into SUD, service providers can get an alert on their phone so that immediate actions are taken to mitigate the relapse. And patients who have mental health problems like depression can also be monitored using artificial intelligence, so that changes in sleep pattern, changes in mood, sociability, and even physiological issues such as sleep and sweating, they can be analyzed by AI system, and then they can serve as warning signs of SUD patients who may be at risk of depression. In view of the numerous advantages of IBH, there is therefore need to strengthen collaborative care for co-occurring disorders. And some of the ways to do this is to ensure that every patient presenting with SUD problems are supposed to undergo screening for mental health problems. In fact, a properly functioning substance use treatment center must, as a matter of imperative, screen all patients, all individuals presenting to the center for mental health problems. And so some of the ways to do this is to use instruments. For example, the patient health questionnaire, 9-item version, and others. And there is need to always establish referral pathways between primary health care and substance use treatment centers. In Nigeria, we have primary health care centers. Ideally, such centers ought to have a properly recognized, properly sensitized drug treatment center that they can refer deserving clients to. And then there is need to encourage partnership between drug treatment centers, non-governmental organizations that are playing a role. So many of them faith-based, many churches, even some traditional institutions, and of course, community centers. This partnership is important if we must strengthen, IBH. There must be that collaboration. How do we address, fragmentation of care for SUD patients? And therefore, how do we ensure that people who have SUD problem, continue to get treatment and they continue to remain in recovery. There is need to develop, guidelines for providing care. We have said IBH is a teamwork, and so you imagine that if there is no clear-cut guideline for duties for various members of the team, then there may be some friction. And so there's always need to ensure that there is a protocol. And we are supposed to have, directories of, various service providers as far as IBH is concerned. So what this means now is that, for example, in Edo State, there should be directory of a record, a listing of various experts who are involved in caring for SUD patients. And this listing should be available at the primary healthcare and the secondary healthcare centers. This will aid referral. This will, prevent the confusion of, who do we bring in? And when these are available, it will help to check the problems of fragmentation and discontinuity of care. Number two, we must be welcoming to SUD patients anywhere they are found. And so arrangement needs to be on ground so that anywhere SUD patient presents, whether at the primary care, whether at GPC, whether at emergency, whether at a maternity, a system ought to be in place that must welcome these SUD patients and thereafter channel them into the appropriate treatment line. The implication of this is that the question of say, oh, this is an emergency. This is not where you are supposed to come to. Come back on Monday, go to social clinic, should not arise. The healthcare providers in such an emergency room, you have the capacity to do something, no matter how minute, no matter how preliminary, and thereafter channel the patient appropriately. And again, there is need for proper coordination between healthcare, education, the justice system, and welfare. And so, many a time, the police can be the agency, can be the first point of presentation, as it were, of an SUD patient. So the police may have made an arrest, only to discover that, oh, this patient has SUD patient. So there must be that coordination, collaboration. There must be a linkage between the justice system at that level and an SUD treatment center, an IBH, treatment center, so that this person who is coming from the police gets into treatment. And many a time, you have people who use SUD, they become homeless, and so on and so forth. The social welfare system can come in. And of course, we can never overemphasize the role of a case manager for every SUD patient. Case manager is just like a local parentis for somebody who uses a substance and is in treatment. How do we expand routine screening and early intervention? They need to integrate IBH behavioral assessments, IBH principles into all primary care visits. So again, when people go to primary care centers, we have stated they should be able to get screening for SUD, some form of assessment, screening for mental health problem. And these frontline workers must be trained, to carry out a brief intervention. And then there is need to make discussions around SUD easy, by always talking about it, and thereby asking everybody, oh, what do you take to pep up yourself? What do you drink to pep up yourself? As we do this, we gradually demystify, SUD. We normalize the discussion around it, and on the long run, reduce the stigma. The integration of trauma-informed practices into IBH is important. This is important because you realize that traumatic experiences, especially in childhood and even thereafter, can be the drivers for initiation and continuing to use psychoactive substance. And so we as practitioners of IBH must avoid re-traumatizing or traumatizing SUD patients. For example, we need to find the appropriate way to obtain a consent before we do anything with SUD clients.
Okay, thank you so much, Prof.
Yeah.
Sorry, Prof. We just need to step in now because of time,
Okay,
to see if we can take some of the few questions that we have already. So thank you very much for this very informative presentation. Your discussion clearly highlighted the importance of integrated behavioral health approaches in supporting prevention, treatment, and recovery for substance use disorders. And a few key points that really stood out, that the need to bridge gaps in service delivery, particularly for undeserved communities, is a priority. And also the importance of early intervention and prevention, especially for young people, to reduce the risk of substance use disorders. The value of evidence-based interventions and peer-led initiatives in promoting recovery and building stronger and more resilient communities. And also practical ways to address challenges such as limited resources, evolving drug trends, and fragmented services, including capacity building, collaboration across different professionals and services, and active engagement of young people. These key points are very relevant to our work and to the work that our participants are engaged in schools, communities, and policy making. They are also reminding us that effective prevention and recovery require coordinated efforts across multiple disciplines, not isolated interventions. Now, we will move on to the question and answer segment. I'll begin by reading some of the questions submitted during the webinar. You can still submit yours if you haven't done so. Let's see how many we can attend to. We have a question already here from Anthony Hall. Anthony Hall says that some of these equipments cost quite a lot of money, and he's asking, will clients be given financial support to acquire?
Can you take that again? Which equipment now?
Okay. Maybe when you were talking about how artificial intelligence is helping.
Okay.
Yeah.
Yeah, okay, thank you very much. The, the AI comes in various forms. Most people, they have mobile phones, they have smart wristwatches. All they need to do is to download the relevant apps, and then they can work with their service providers to see how such apps can be used to further their treatment. So it is not something that every patient must go and buy such a phone or such a smart wristwatch. What I have tried to do here is to try to highlight how IBH tries to take advantage of the matter of the time, which is the digital system we have found ourselves in. Those who don't have such facilities, most people have a phone. I mentioned SMS. I mentioned WhatsApp messages. I mentioned even telephone call. They can benefit from all this. So there's never a time government or service providers will now provide smart wristwatches for clients or phones for clients. But those who have the capacity, those who already have such gadgets, one can explore the possibility of taking advantage of such devices to better their care. Thank you.
Yeah, thank you so much, Prof. I believe the question has been properly answered. Another question is coming from Abibat Akintobi. And Abibat is asking that you mentioned the use of AI innovation for detection of some behavioral changes. Her question is, are there any tools available presently? And if so, please, can you mention the tools, if any application can be used?
Yeah, well, the one that is common that people are using, if you have a smart wristwatch, for example, um, it can help to monitor your sleep. The smart wristwatch, if you activate the relevant setting, can by the following day tell you that, oh, you have slept for so number of hours. Now, if, for example, your total sleep hours started dropping, especially where the pattern is so that you are waking up earlier than you used to wake up, and you are a person who is on treatment for depression, or
Hello, Prof. Well,
Hello, Prof.
okay. As we wait for Prof to come back, I'll just hand over to the ISSUP Nigeria director, Dr.
pointer.
Koyechi. Okay, we have Prof back. Excuse me, Prof, we lost you at some point. Is it possible for you to just go back to where you were talking about if the person has depression? Oh, so Dr. Koyechi, please, can we just get your inputs from what Prof has been saying?
So good afternoon, good morning, good evening from Nigeria, depending on where you are. I really want to just give a brief summary of this webinar, and it's really important for us as addiction prof. Okay, Prof, I think Prof is back. Prof, your mic is
Yeah.
muted. Hello, Prof. Can you unmute your mic? Okay. So while we are trying to sort out the technical glitch, the whole essence of integrated behavioral health, by what I know, okay, Prof is back. Okay, thank you very much, Prof. We appreciate that. Prof, are you back?
Well, we've just lost him entirely. You can just continue.
Okay, so it's just about holistic care of our patients, giving our patients the care that they deserve, treating them as a whole, not as substance patients, but as a whole human being, treating them holistically, bringing together the biopsychosocial approach in getting the best outcome for our patients. And this is a standard we must aspire to achieve in all of our treatment services. I especially want to thank Prof. Adayo for, especially this afternoon, for stepping in to give us his wealth of knowledge about this program. I want to thank the moderator, Mr. Ejikeme, and every one of us for coming on board to be part of this webinar. I'm sure we've learned so much. And for me, the key take home is we should treat our patients holistically. We should not treat the substance, but we should treat biologically, psychologically, and socially. And with this, we get the best possible outcome for our patient. And our practice would be the evidence based in which we are pushing will come to bear. Thank you very much, everyone. Back to you, Bishop.
Yeah, thank you so much, Dr. Koyechi. In fact, you have just summarized the whole session in a few minutes. Thank you for that informative summary. As we bring this session, the 30th session in our webinar series to a close today, it is evident that integrated behavioral health approaches are practical and effective tools for bridging gaps in the prevention, treatment, and recovery of substance use disorders. And I believe that our participants have gained one or two tools they are going to use in their work. And on behalf of ISSUP Nigeria chapter, I sincerely thank you all for participating today. We look forward to seeing the impact of today's discussion reflected in your work and to welcoming you to future ISSUP Nigeria chapter webinars. Thank you. See you in our next webinar. Bye-bye.
Bye, everyone. Thank you very much.